Well, we've been talking about the exciting world of psychological testing. And we had just introduced, a very famous test in psychology, the Minnesota Multiphasic Personality Inventory, more often referred to simply as the MMPI. And this really is an interesting test. I had just mentioned at the end of the last class that it was developed at the University of Minnesota by a well-known psychologist there, Stark Hathaway, and by a psychiatrist, J.C. McKinley. Now, what they did is they took 1,000 items that they had developed. And these were items, great range, they range from things like, I like flowers, I frequently hear voices, life seems meaningless, I have frequent headaches, all kinds of statements that, most of which referred to symptoms. And you answered them true or false or cannot say. And so cannot say meant that you felt this is something that really doesn't pertain to you. Then what they did is they compared, they compared the scores of people who were seen as healthy, the so-called normal population, with people who were known to have a certain diagnosis. So they had, groups of people who were schizophrenic, for example, take the test, and then they would see, like, what would they score high in? And whatever, and people who scored after a certain cutoff point that I'll show you in a moment, those people would be seen as pathological. Meanwhile, everybody would answer some of those items in a certain direction. It was when you answered the preponderance of items that you got into the pathological area. Now, it's an interesting test because not only does the MMPI measure psychopathology, which is what it's intended to measure, but it has various test-taking scales that tell us how honest and how accurate are the results we're getting likely to be. So the first thing that happens with this test is it scores for how many questions. By the way, the original test was about 565 items. And the first score that comes up is a score regarding how many items did a person skip. And the interpretation of this item is usually that a person is attempting to avoid disclosing things about himself or herself. But sometimes it's been discovered that people who skip a lot of items have difficulty in understanding the test. They may even have difficulty in reading the test. And so you want to be careful. For instance, if you give this test to someone whose native language is not English, and you haven't checked for how well do they read in English, they may end up not answering a lot of items because they honestly don't know what they mean. Well, that's important to know that because then obviously the rest of the test you wouldn't want to rely on much. So, but anyway, the so-called, this first item on the test is how many items did you skip. Now then, there's a very interesting, the second scale on this is called the lie scale. And it consists of statements which, if answered honestly, reveal mildly negative characteristics. Like, there's an item, I keep up with the world news every day. If you answer that true, we assume you're lying. That is, it's a rare person who keeps up with the world news. It's every day. I would say they make the statement. Whereas if you put false, they assume you're more open to being honest and admitting to a minor problem. You don't keep up with the world news. Or if you answered an item like, I smile at everyone I meet, and you put down true, we assume you're lying. Because not everyone that you meet is likely to be someone that you will smile at. So by what we're trying to do is get at your test-taking behavior. Are you open enough that you can look at an item like this and say, no, I don't keep up on the world news every day. No, I don't smile at everybody. If you're willing to admit to those things, then it is more likely you will be open to admitting to certain symptoms that are going to be measured with other items. But if you don't answer these items in that direction, then one has to be concerned that you're going to be so defensive on the test that we won't get a real picture of you. And this particular item actually has shown to be pretty accurate. That is, most people do answer the questions the way you would hope they would. That is, that they do disclose that they wouldn't do some of these things. Therefore, they're not going to be lying on the rest of the test. Then there is a scale called the frequency scale, or the F scale. And it contains, it contains items rarely endorsed by normal people. But they're not necessarily associated with a specific pathological group. So, in other words, they may be associated with pathological groups, but not a specific one. But with normals do not answer these questions normally in the pathological direction. And so, if the person gets a high F score, it usually indicates that there's either a carelessness in responding, which might be interpreted as the person's really quite confused, or the person may be purposefully wanting to exaggerate symptoms. And so they check everything in the pathological direction, and that's not helpful. Now, one of the problems, though, with this particular scale is that schizophrenics often score high on it, because schizophrenics are often confused when they're taking tests. So they will check a lot of these items, and the test becomes not valid if there are too many of these items chosen. And I'm going to show you in a moment, when we look at a profile of this, just how this works out. These are items, by the way, like, there is an international plot against me. And you answer that true. You don't find many normals who are going to answer that as true. But you are going to find a lot of schizophrenics who are going to answer that as true. Now then, there is a scale, and by the way, this is all on page 186 of your book in chapter 5. This is all well described. Called K, and it's a correction factor. Don't ask me how they came up with K, because I don't remember. But it's a correction factor, and it's to detect a client's tendency to be overly defensive or overly disclosing about the problems. So if you get a high K score, it's taken as evidence that a client is downplaying the severity of his or her problem. There's an item, for instance, I feel bad when others criticize me. If you answer that as false, we assume you're being very defensive. I mean, I feel bad when others criticize me. I mean, certainly one would answer that as true. Most of us do feel bad when others criticize us. So if we say, no, I never feel that way, well, that's probably pretty defensive. So what happens with this scale, by the way, is interesting, is they have found a statistical way to take the K-score and with certain of the scales, the clinical scales, to add a factor to the clinical scale so that the defensiveness can be incorporated into what the person's real score is. So we find in some of the clinical scales that by adding a factor here, a percentage of K, we actually get a true sense of how the person would score on that scale. And again, I'll show you this in just a moment. Now, the MMPI was revised in 1989, and they really did update some of the items on it. And also a lot of additional scales were developed besides the 10 classic ones that I'm going to show you. But they developed scales, for instance, to measure anxiety. so that they could get a real measure of just how much anxiety someone experienced. We have a lot of anxiety scales in psychology, so and this is just one of them. But they also developed like a scale for alcoholism, which is, a very common problem in coming into so many clinics. So they developed a scale that would measure whether or not someone really had a serious problem with alcoholism. Now, as I mentioned, if you look in chapter 5 of your book, you'll see a list of the scales. And let me just show you. This may not be real easy to see, but this is right out of your textbook. And you'll notice there are 4 scales that you will see. Well, actually, on this, there are 3 scales that you see because the question mark scale, that is the ones that you skipped, doesn't come up here. But you'll see there are 3 scales, L, F, and K. Then there's a line. Now, the L, F, and K are the validity scales we just talked about. And the purpose of those is to see whether or not the test is valid. Now, when you look at this, you'll notice there's a 50th percentile actually is across the bottom of this. As you notice, it goes down to the 30th, but there's a line across at 50. That's considered the average. Now, that's the normal range, and there's one at 65. And what this means is that anybody who scores in that range, that is basically people who score below 65, are considered to be normal. And that means they don't have that problem. You don't want to interpret that somebody, because someone has some items answered on a certain scale, that means they really have that problem. Unless you get into the pathological range, these scores are not important for the most part. Also, you're seeing this test now, and you're seeing 65 as representing the pathological range. When the test was originally normed, actually 70 was the range, but they redid the test. That is, they redid the norms, and so they made 65 the pathological range. And a lot of work had to be done to really get to understand the difficulties of measuring all these scales. Now, your very first scale, you'll see, once you get past the first 3, so you get to a scale called HS, which refers to hypochondriasis. And here, and this is a very important scale often in clinics where we're trying to determine is someone actually physically ill or is somebody really just hypochondriacal. And there are 32 items that are in this scale. And it was derived from patients showing abnormal concern with their bodily functions. Someone who is examined and already been shown that they don't have a heart problem, they don't seem to have any chest problems, and yet the person answers, I have chest pains several times a week, and the answer to that, true. Well, we assume then that person is really hypochondriacal. Now, that's one. You have to answer several of those questions, of course, in that direction before you would be pathological enough to be diagnosed this way. Now, the next scale is a scale called depression. And now this scale has actually 57 items. So there are lots of items that are scored for depression. And this is where a person shows extreme pessimism, feelings of hopelessness, slowing of thought and action. There's an item, I usually feel life is worthwhile and interesting. If you answer that as false, then that's in the direction of someone being depressed. Now, the next scale is derived from a very old-time concept in a way. It's called HY, actually refers to conversion hysteria. Now, quite literally, if you've taken abnormal, you studied that conversion hysteria originally referred to people who develop physical symptoms with no physiological basis. The most classic ones are like a person who is said to be hysterically blind. A person can't see, and they really can't see, but there's nothing wrong with their eyes. Or we've had people who are hysterically paralyzed, let's say in their legs. They can't walk, but there's nothing wrong with their legs. But there are psychological reasons for why they can't do things. Now, that's what this was really trying to measure. It's broadened now, so that now it usually refers to neurotic patients who use physical or mental symptoms as a way of unconsciously avoiding certain conflicts. Or they may be trying to avoid responsibilities. An item on this is, my heart frequently pounds so hard I can feel it. The answer to that, true. We see that as an hysterical symptom. Now the next scale, so the fourth scale going over here, you'll see is PD. And that scale means psychopathic deviant. Very old-fashioned term, and we don't use those terms anymore. But it was 50 items that were taken from patients who show a repeated and a flagrant disregard for social customs, or people who have a really emotional shallowness, or an inability to learn from punishing experiences. And there's an item, a typical item might be, my activities and interests are often criticized by others. My activities and interests are often criticized by others. And the answer to that is true. Now, what's implied there is you don't learn from that. People tell you you shouldn't behave this way. Doesn't matter. You keep on doing this because you're simply going to do it your way. You don't pay attention to society. So this is seen as a scale likely to tell you that a person doesn't have a lot of control of their anger, that this is a person who is not a cooperative person in a group. This is a person who often lashes out at things. And that's the kind of concept we're trying to measure. Now the next scale, the fifth scale, is called MF, masculinity, femininity. And this scale, you want to remember, was developed before the time that the American Psychiatric Association finally understood that homosexuality should not be listed as a disorder, that homosexuality is one of the ways in which people lead their lives. So this test originally was trying to pick up on homoerotic kinds of behaviors, but also it was a way of differentiating between men and women. So you had items like, I like to arrange flowers. And if you answer, I like to arrange flowers, true, it was scored in the feminine direction. And on this test, by the way, in that scale you see before you, that's MF, you'll notice that this is a female now that we're looking at. As the person answers more and more questions in the female direction, her score goes down. Now, on this particular scale, if you were looking at this for a male, you would find that as that person answers more and more questions in the feminine direction, their score would go up. And so the idea being that if the male answered a lot of questions in the feminine direction, that would mean that this person may well be homosexual. The reality was the scale never worked. That is, this scale was never a scale that detected homosexuality, and it was operating on the wrong premise anyway, that homosexuality somehow would be a deviant style of life. What it did do, though, is it ended up making some differentiations between educated men and less educated men. That is, educated men tended to score higher. Educated men tended to answer a lot of the feminine questions that is, answer a lot of the questions in the feminine direction. So a man, and especially secure men, might end up saying things like, yes, I like to arrange flowers. It might put that as true. I like to go to the opera, true. I like classical music, true. All of those things were scored, by the way, in the feminine direction. So a high score on this particular scale probably only told you that there's a good chance that this person is a sensitive person. That is high score for men, low score for women. Would tell you this is probably an educated person, perhaps a rather sensitive person, sensitive in the good sense of that. But it is really not one of the scales that measures pathology. However, the next scale does. The next scale we go over is PA, standing for paranoia. And here you have items that show, really abnormal suspiciousness, even to the extent of like having delusions of grandeur, delusions of persecution, and an item like, there are evil people trying to influence my mind. If you think about that, now that's a good paranoid delusion. If you answer that true, you're going to score positively on the paranoid scale. The next item, or next scale over, is called, it just shows up here as PT, which stands for psychasthenia. And this refers to patients who show obsessions, compulsions, abnormal fears, a lot of guilt, people who are indecisive. And so a typical item in this scale is, I save nearly everything I buy, even after I have no use for it. So if you answer that as true, you're not just a collector. You are obsessed with things. And if you answer a lot of questions in that direction, then what you're really saying is that, I just can't let go of anything. Now again, the next scale after, and as you can see, we're getting into some pretty serious things. The next scale, of course, is the schizophrenia scale. And here you have 78 items from patients who show bizarre or unusual thoughts, unusual behavior. Often these people are withdrawn, they're experiencing delusions, perhaps hallucinations. And I thought one a great item actually they put into this, is things around me do not seem to be real. And the person answers that is true. Anyone answered that is true, there's a good chance that that person is schizophrenic. It makes me uncomfortable to have people close to me. And the person answers that is true. Now that's not nearly so pathological. But when you start answering all the questions in this area in the same way, and the score gets high enough, then the person probably is schizophrenic. Now, the next scale you'll see is MA, standing for mania, or hypomania was the original term. And this is characterized by emotional excitement, overactivity, people have flight of ideas, their ideas just go in all kinds of directions. And the items they've put into this category are things like, at times I feel very high, or an item like I feel very low, for no apparent reason. And this scale then is kind of measuring that emotional lability that people have. Finally, the farthest scale, the one on the far right, SI, is not quite a clinical scale, but it is put in here. It's called social introversion. And this is a scale that measures shyness, people who have little interest in other people, people who feel insecure, person who answers the item, I have the time of my life at parties, they answer that false. They score in the introverted direction on social introversion. Now, on this scale, what can be meaningful is that somebody who scores very low is interpreted as being outgoing, being very active socially. So while the attempt here is to really measure, is the person introverted, withdrawn, someone who doesn't do well socially, one can conclude from a low score on this that the person probably got pretty good social skills, and they probably reach out to other people. Now, this test certainly has been shown when it first started to not work well if you weren't your typical kind of middle class American person that with some education. I remember when when I was running a doctoral program one day, this graduate student, very bright graduate student, comes in to see me, and she says, I just started this course in psychological testing, and I want you to know you've got a guy teaching this course you got to get rid of. So I'm thinking, wow, this is pretty strong. She says, you know, this guy is teaching us this test about the MMPI. And he says, today, he was using an example, he says, if there's an item called, God frequently speaks to me. And this guy says, if you answer this true, then you're likely schizophrenic. Now, this woman was a full-blooded Cherokee Indian. And she says to me, if this is true, the whole Cherokee nation is likely to be schizophrenic, because every Cherokee would answer this item as true. And I remember, you know, being so struck by the fact that I had to sit down and we had a great discussion about the fact that you really wouldn't want to use this test with Native Americans. And indeed, later on, they did try to work out a way to score the test so that if Native Americans, you know, that is people who really were active in tribal affairs, people who were born on the reservations, grew up in that kind of culture, very much adhered to Native American traditions, that some of these scores had to be changed, or else you would not get an accurate picture of the person. But I was really struck by how quickly this woman, who was a very sharp person, picked up that there is something very wrong with this test. And what I was struck by was that, you know, there wasn't much attention paid to that. It was really, it was shortly after that time that the people who actually created the test began to make changes in it. But we have not always been sensitive to cultural issues. And so if someone comes from a culture different than kind of the mainstream US culture, you want to be careful when you go back on this test and interpret it. If it seems not to fit the person, there's a very good chance it doesn't fit the person. Now, you don't diagnose a person with a disorder simply because they score high on these scales. But what you do with these scales is they're very useful in differentiating certain groups. I mean, people who score high on some of the scales, like towards the left side, are more likely to have certain kinds of personality disorders, whereas people who score high in things like paranoia and schizophrenia are much more likely to perhaps be psychotic. So you can kind of differentiate people into certain groups. Now, if we go back to the original profile we had up, if we could have that up. Okay, now take a look. Now, you look at this profile, and by the way, this is how the data are presented. That is, we look at the whole picture. We want to see how somebody scores on all of the scales. The first thing you look at are the three scales on the left. Now, what do you learn from the three scales on the left? What would you say about this person? This is a female. Look at those three scales. What could you tell me about her?
Pretty honest.
Ah, yes. Sure. Very important. This is probably a valid test for her. Eh? You notice that those scales are all below 65. So this is someone, and as you say, you know, the defensiveness score is down around 50. So this is a pretty open person. We make the assumption with this woman, she took this test with the attitude we would want. That is, that she probably, you know, answered her items in an honest direction. And she's not bizarre. She's not somebody who, you know, couldn't understand the test. And she's not somebody who had a lot of, you know, idiosyncratic ways of approaching items. Okay, so now we get over and we get to our 10 so-called clinical scales. Now, what can you tell me about this woman? You're looking at these scales, and you're the person whose job it is to interpret the test. What do you see?
Maybe a little bit of hypochondria.
Okay, and you say that because
The HS scale
is
a little above 65.
above 65, so it's in the pathological range. So the hypochondriasis scale is in the pathological range. What else can you tell me? Sure. Mr. Inman?
She might be pretty depressed
And why would you say that?
because the depression scale is way above 65.
Yes. So you look at this. In fact, the first thing you notice is that the most extreme scale is the depression scale. So you look at that and you say to yourself, okay, maybe the primary issue that this person has to deal with, at least we can consider that as depression. Now, what else do we learn?
Her psychopenia scale is high. If I'm seeing that right.
That you are seeing that right? That is correct. Okay, now what does that tell us?
She's probably depressed because she's feeling guilty about some things. She's having some abnormal fears and some.
Okay, that's good. No, you're doing that's just fine. Okay, now notice that in this particular profile, you've got someone who has D scale is the highest. Okay? So this person's depressed. Then we've got a person. The next highest scale is the psychasthenia scale, which we've said, it shows a person who may be, compulsive or obsessive or have a lot of fears. And we also have just above into the abnormal range, the hypochondriacal scale. Now just, let your imagination go. How do you suppose this person presents? This person's going to go seek help. How do you think they're going to present?
Anxious.
Okay.
Fixated on things and kind of I don't know. Like really self-attribution stuff.
Okay. You see her as probably someone who will present as anxious. Now let's just ask, but her highest score is depression. Why do you think she'll present as being anxious?
She's also scored almost as high on the obsessive.
Okay. So you think that those features you will see, which by the way is quite possible. What else might you? I realize it's difficult, by the way. It's not easy to do this, but it'll give you some flavor for this kind of thinking.
I kind of see her as wrong, but I'm not real sure how I can justify that. I mean, she's depressed, but even though she's obsessive compulsive, to me, it just appears that she's expressing a lot of guilt, and I don't know. I see her as being intimidated.
Mm-hmm.
Where is she on the SI scale?
Well, you notice that she is halfway between 50 and 65, so she's in very normal range. So one would assume that is not a problem that we would identify for her. Okay, now here's just where clues come in. Why a test like this is helpful. It's you're all picking up on really the major issues. That is, this is a depressed person. This is a person who probably fairly rigidly controls her behavior, is very frightened of a lot of things. But the clue in here is this hypochondriasis scale. It is likely that this person shows up in their physician's office. That is, it would not be unusual for someone like this to show up and be complaining about headaches, chest pains, any number of vague aches and pains, because that's one of the ways in which she gets out, she can express her feelings. However, and unfortunately, many people like this do present. And then they get treated for those. It takes a while for the physician to treat her for a number of these pains and come to the conclusion this person doesn't have any of these pains. The physician probably will have run some tests and have determined there's really, no problem that he or she can detect about why this person has headaches or why this person has chest pains or why that person reports rapid heartbeat or things like that, because the tests don't show there are really any physical reasons for this. That's when often then physicians begin to recognize the person is probably depressed. And so now if it's a well-trained physician, the person will refer them to somebody in the mental health field at that point. and really have them examined for what this is all about. Now, what you'll find is that while the person is depressed, the fact that the psychasthenia scale is so high tells you that depression might even be a defense against all kinds of intense feelings that are breaking through for this person, and they're fighting them. So the depression is their way of controlling the fact that their obsessions are getting out of control, that their ritualistic behavior is getting out of control. It may, for instance, it may have occurred that these things have so bothered people around them that they've lost their job, that they're not very functional. So in this case, the depression is only a symptom to tell you that there is reason for why the person is feeling so bad, but it's not just that they're depressed. It's that they're fighting some other kind of struggle. You'll also notice, in this, that this is not likely to be cyclical. That is, if you look at the mania scale, manic score is pretty average. So if the manic scale were way down, you might be worried that this person fluctuates between being depressed and being very manic-y. But in this particular case, you're probably looking at someone who's mostly depressed. Now, why this test is helpful, you remember I was telling you this was developed at the University of Minnesota, it was developed in the medical center. One of the things that they did at Minnesota for a long time, they gave this test to everybody who came in. Every medical patient got this test, if they were willing to take it. They had to agree, but you began to see then that a lot of people who presented with physical complaints really would better be treated psychologically. And there are significant data today that we'll discuss in more detail, but there's significant data to show that almost half the people coming to see a physician have a significant psychological problem. There are some data to suggest that 50% of people going to see a physician have only a psychological problem. So when you give out tests like this, often they're very helpful in screening people and in getting a sense whether the problem that people are coming to present is a physical problem or whether there's a psychological problem. So you give them a test like this and the person scores high on some of these scales, immediately it's an alert to a well-trained physician that I better look further than just at the presenting problem. All right, now, excuse me a second here. Now, as you can tell from my description, that this test was developed from getting patients to respond to a number of symptoms and then comparing the normals against the abnormals. And as I say, it's not a test that necessarily leads to a specific diagnosis, although I must say it is not uncommon that people who score high on the schizophrenia scale are diagnosed as schizophrenic if you can rule out drug abuse. But if those symptoms are really not caused by drug abuse, then it's quite possible that they're really having trouble they're having a thought disorder and they need help. Now the test ended up getting even more use. I mean, first of all, I'm talking about a lot of use. After all, if you're giving this to all the patients coming into a big medical center, that says a lot about your attempt to get psychological information. And remember now, there's 565 items that make this up. So it takes the people a while to do this. Fortunately, of course, it doesn't take a lot of time on the part of any professional because you can give the test to the person in a room, explain that they're to go through this and check items that are as true or false, or if they cannot say, to put down cannot say. And then the test goes to a copy, or goes to a testing person, who can just score it on a machine. So the test can be given to someone, and then this format that we have can be developed, and no professional person has really had to do anything yet. So you have all these data, and you haven't had to do anything, and that's very helpful. Now, what then happened was the test started to get used in other ways. This is a test that was given as a screening test in lots of places, probably still is. In religious communities, for example, the men and women who were seeking to join various religious orders often took this test. And norms were developed for them so that you would be looking for a certain kind of profile. It's about whether somebody was looking particularly normal and healthy. You did not want to be taking people, let's say, who were very high on social introversion, high on depression. You did not want to be taking somebody who is scoring very high on psychasthenia. That is, you didn't want somebody whose behavior might be very rigid, might be very difficult to live with them in a community. So the test became a mechanism to learn about candidates in that world. As well as, we talked about this before, but people who are going to work for the CIA or the FBI, et cetera. It's one thing to have a healthy skepticism about people. It's one thing to be very socially alert, to be sharp about what's going around. But you don't want somebody who's going to score high in paranoia. That is, you don't want somebody who is actually going to see things that aren't there. You're looking in those jobs for people who are really interpersonally sharp. That is, if they're going to work out in the field. And so, but it doesn't help if they're paranoid, because then they may be seeing things. In fact, they will be seeing things that really aren't there, and they will not be sharp in picking up reality. And there's a real difference between being someone who is interpersonally very sensitive, very aware of what's going on in a room, very aware of what's going on in relationships, and someone who is paranoid. The first person I described, who's very aware of what's going on in relationships, really is picking up on the true cues that exist between two people or exist in a group of people. Like they're very sensitive to the dynamics of people. The paranoid person isn't picking up on anything outside. The whole premise in paranoia is these things are being generated from inside. This is the person who imagines that they're being followed because that's what gives meaning to their life. This is the person who thinks someone is trying to harm them because they have extraordinarily intense feelings of vulnerability. It has nothing to do, though, with the outside world. And that's why the paranoid scale becomes important if someone scores high in it. It tells you that what they're picking up on is a lot of confusion inside themselves, not that they might be sensitive people.
It has to be rough for whoever is actually being followed.
Pardon?
It has to be rough for people that are actually being followed.
Well, if you lived, this is interesting. You're saying it has to be rough for people who are actually being followed. Well, you can see in some of the Eastern Bloc countries, for the stories we read before the fall of the Berlin Wall and certain times in the past, people probably were being followed. They knew that, and certainly there was no question. Just as the Second World War broke out, if you were Jewish, you were very worried about being followed, but that was not paranoid. That's was the culture you lived in. That was the world that was very frightening, and you had to be concerned about it. And certainly today, as you follow the skirmishes that are going on all over the world, you realize some people do live in a world that we refer to. It's interesting you bring this up because we refer to it as a paranoid world. But it's not a paranoid world. Were that it were a paranoid world, it would be easier for them. They are living in a world in which being suspicious is healthy. Being suspicious is what real life is about. There are people looking to do harm to other people. If you walk out of your house in Northern Ireland and you look both ways, that's probably not a bad idea, at least up till recently. Now, Northern Ireland's had rather extraordinary peace for a couple years. If you're boarding a tourist bus in Egypt, you probably want to be a bit uneasy because people blow up tourist buses as they travel around. We know these data. So those kinds of things are distinguished very much from the items on this test. This test really is looking at those people who develop a suspicious world because of their internal conflicts, not because there actually is threat out there. Once you start talking about threat out there, then you're talking about reality. And by the way, this test won't pick up whether someone is suspicious about that or not. Okay, now that we've looked at this test, there are many, many other tests that we could have looked at, and we just don't have time, but I want to try to take you into various categories. I will mention, though, that when you look at this, there's a scientific base to this test. That is, they've taken large populations, they've compared how people score on certain items against, with normals being compared to abnormals, etc. There's another way you can go about doing this, and there's a man named Cattell that when you take personality theory, you'll study. And Cattell developed tests measuring all kinds of variables, but he did it by using a statistical technique called factor analysis. And what he did is, in his situation, he took a very large number of variables, and he wanted to see what items are intercorrelated. Intercorrelation means like when one item shows up, there are several other items that are likely to show up. For example, let's describe somebody as being aggressive, forthright, impulsive, a take-charge person, and opinionated. Okay? Now, if we say that somebody who meets this description, that is aggressive, forthright, impulsive, opinionated, they're a take-charge person, Cattell might say you could use a term like assertive and say that the assertive person is likely to have all of these descriptors. So you don't have to describe somebody, he would say, you don't have to describe somebody as being opinionated and take charge and aggressive. Just saying they're assertive is enough to tell you that. That is, that when the variable of assertiveness appears, all of these other items also are likely to appear. And so Cattell then developed a number of factors, and he fooled around with various clusters and things like that. And eventually he came up with literally 171 terms that he thought were descriptive of people. Now, he started out with 4,500, and he reduced 4,500 terms to 171. Then he found that even these, if you took the 171, that a lot of these items correlated with one another. So he got down to a point where he ended up with 36 clusters of correlations. And he decided to call these things surface traits. Later on he added 10 more, so he ended up with 46 surface traits. Then he found ways to measure them on scales. Not quite like this, but on bipolar scales, so that either a person was at one extreme or they were at the opposite extreme. So if you took something like, say, joyful and sadness, at the extreme, the person would be always full of joy and happiness and excitement, and at the other extreme, the person would always be very depressed and lonely and unhappy. But his feeling was that most people fall, in between this, and so you get to see, are they leaning in one direction or another? Now, an interesting thing that Cattell did too is when he developed this test, by the way, this is given very much like the MMPI, a bunch of items, and you answer the items, or you score the items wherever you think they fit for you. But he gave this test to people for across many, many years. Like, he started studying this early in his own career, and he gave the test to people who were able to follow the same individual. And he did find things like he had a measurement for superego. And he found that there is that the score on superego control declines gradually over years. That is, that people become less and less ruled by what we might think of as a superego as they get older, which would imply that as people get older, they begin to make more of their own judgments about what are really the good things in the world, what are the appropriate things in the world, and they're not driven to do certain things simply because they will be rewarded or not rewarded for those. Now, one shortcoming in factor analysis is that when you take these clusters, and I realize I've moved quickly through this, but I just wanted to give you a flavor. The one problem is you have to name the cluster. And so depending on the name you give the cluster, you're saying that this factor is such and such. Like the cluster I gave you and said we could say this is assertive. If I'd have asked you, probably a lot of you could have come up with other terms that you would have used. And so the question becomes, when you name a cluster, can you find a word that is descriptive enough that when a person hears that word, they will realize that these other variables also are a part of that. Okay. Now those are a couple we've just touched on now are seen as objective personality tests. The MMPI by far is the most popular of these, best known, heavily researched. But there are other kinds of tests. And we're going to move on to what are called projective personality tests. And this is really a very old form of personality assessment. One of the first modern tests comes from a word association test that was actually developed by Sir Francis Galton back in 1879. And then Carl Jung in 1910 really made this word association test known and used it a lot. Now, when we talk about projective techniques of personality assessment, what we're saying is we give people stimuli. It can range from fairly specific to extraordinarily indefinite. And what we assume is the answers we get from people will be projections of their personality. Now, when you use word association, for example, if I say water, you might get a wide variety of responses to water. I mean, it just depends. If somebody is feeling thirsty, they might say thirsty. Somebody else might respond ship. Another person might respond vacation. I mean, there are all kinds of things that people might come up with. Now, the actual response to stimuli is usually not that important. That is, it's the content and the context of the response that becomes important. So if you say something like water, the person says gray. That's fine, but that doesn't tell you a lot. On the other hand, if you give a series of words, so you say cloud, the person responds dark. You say land, the person responds barren. Then you might begin to suspect this person's depressed. I mean, every response, barren, gray, all the descriptors, and so you use the word association test to follow people and to see what kind of cluster of responses do you get. Now, I'll go on and give you another example when we start our next class about how this test works, and then we're going to move into other projective techniques. But we'll take a break for right now.